All right, here we go. Coagulation. Prevent shock. Shock is a lack of blood flow. And what could cause shock? There's a few things I have listed on this slide. Since we've had cardio, I think you understand that a heart attack, if you have a damaged heart muscle, blood will stop flowing in the systemic arteries. That could cause shock. Vascular shock. If you can't vasoconstrict the peripheral blood vessels, particularly the arterioles, they'll dilate. Then all the blood will just leak out of the arteries into capillaries in the veins, which can hold the blood, and blood will pool in veins away from vital organs. That'll result in ischemia and shock. Okay. Sometimes if you have a head injury that damages those vasomotor fibers, that causes this kind of problem. So they call it vascular or neurogenic shock. Hypovolemic shock is just excessive blood loss due to hemorrhage or bleeding. And we talked about this slide before, and I'm not going to reteach it, but you understand that if the bleeding doesn't stop, eventually arterial pressure drops along with cardiac output. So this is kind of why we study hemostasis, which is a fast coagulation reaction of blood in response to vessel damage. And you want this coagulation or hemostasis to occur at the site of injury. So the whole process of hemostasis ends with the coagulation phase, but it may be preceded with a vascular phase or a platelet phase. So I wanted to define all the phases that can prevent shock and bleeding. Step one, vascular phase. This is a spasm event. Could you just call it vascular spasm? So we know the vessel structure, TI, TM, TA. A spasm is basically TM, right? Because that's the smooth muscle cells contracting, causing a vasoconstriction. So think of a spasm as a vasoconstriction event. You increase the resistance for blood flowing, and you're going to minimize blood loss. Well, here's a picture of it. The spasm. Cut a vessel, and the pictures, you try to prevent or minimize blood loss. And to be technical, you're decreasing the transmural pressure. Recall that vessel radius really affects resistance to blood flow. I mean, you can help. You can apply pressure. That'll help. Putting pressure to the wound will basically help the spasm. But I'm just talking about just what happens to the blood vessel itself with no outside help. Now the second step is a platelet plug formation. What may be difficult to see in the picture is there's a little break, and that's where this is occurring after the spasm, right there. There's collagen fibers that are exposed from the underlying endothelial layers. And the platelets, they just kind of stick to the exposed collagen fibers. Okay? That's how this thing gets started. So platelets stick to exposed collagen fibers. Now that starts a process of platelet activation, but I first want to sidestep a little bit and remind you where platelets came from in the first place. Platelets are thrombocytes. At the beginning of class today, go back and look at your notes. I said that the hemocytoblasts, that they're exposed to, they're stimulated by TPO. You get the megakaryocyte. The megakaryocytes, the cells that produce platelets, they increase in size and number, thereby increasing circulating platelets. So what we learn about platelets from this picture, they're derived from the megakaryocyte. They're literally just flaking off the cytoplasm of the megakaryocyte and enters circulation. So platelets are packets of cytoplasm. They're not fully formed cells. This is one of the reasons why we refer to blood cells as formed elements. The platelets are formed. The megakaryocyte is a cell. The little things that flake off we call platelets. They're not really true cells. They're formed elements. And so here are some features of them. I would say, basically note this. They have a lot of membrane proteins. That makes them sticky. Their job is to stick to the exposed collagen fibers and stick to each other. They also transport many chemicals, which I'll define, that are important for clotting. So here's a picture under 44,000X of platelets being trapped in a fibrin mesh. But I wanted to show you this right here because these little cells have been activated. Those are activated platelets. Okay, and I think that's a good visualization of what an activated platelet is. When we look at platelets on a blood smear slide, such as this, the little fragments, those are the platelets. Okay. They're all over the place. Mostly I see red blood cells. I see a couple of white blood cells, monocyte, neutrophil, but these are all platelets, the little fragments. Here's a professional picture of an unactivated platelet, activated platelet. So there are many differences that occur when you have a platelet stick to exposed collagen fibers. Platelet activation occurs as a result. Platelet activation involves, as you can see from the picture, morphological changes. They just kind of puff up and get really spiky. Morphological means change the shape. So maybe you're a small little fragment, but when you get activated, you get big and puffy. You increase the exposed number of membrane proteins, so you're better at binding other platelets. You're also going to secrete a lot of chemicals. This slide I included to show you how the plug forms. It's very important that you localize platelet aggregation to the injury site of the cut vessel and nowhere else. You fill the edges, and you can see the tunics that are damaged on this large vessel. And you see that the spasm has already occurred because these cells have not contracted. These cells have, that's why they're larger. And they help kind of begin to mine the gap, I guess, but you fill the rest of the gap with the platelets that have bound to each other. And when platelet aggregation occurs, you get the morphological changes and you secrete more chemicals to increase aggregation. And those chemicals are, I have them on the next slide, ADP, adenosine diphosphate. ADP, in this lecture, it's an aggregating agent. ADP, aggregating agent. Others that are commonly listed that help increase the platelet plug formation: serotonin and thromboxane A2. Give a couple more. Serotonin, thromboxane A2. Both of those help increase the aggregation and the spasm. So I'll put up arrow aggregation. I'll put up arrow spasm. So just to give you a few chemicals to know, this helps exacerbate the process. This is a positive feedback cycle. I'm going to go back to the previous slide. So put your note, this is positive feedback. What is that? The secretions increase the original stimulus. So you get some platelets activated, they bind, they activate, they release chemicals. They attract more platelets that become activated, that secrete more chemicals, that aggregate more, and then she keeps going round and round until you plug it up. Okay, it's positive feedback. And the thing about this is it's important to localize the aggregation only at the injury site. So know these chemicals here, prostacyclin and nitric oxide. They're released by uninjured neighboring endothelial cells to concentrate the aggregation only at the injury site. Let me write that down somewhere here. Nitric oxide, NO, prostacyclin are secreted by uninjured ECs, endothelial cells, to localize platelet plug to injury site. You don't want you don't want it aggregating at uninjured parts. You just want it to fill the gap, okay, until the real solution comes, which is fibrin. Okay, that's the real clot. This is kind of like an initial kind of a stage, and well, let's kind of get to it. Step 3, the main step in coagulation, is to form fibrin mesh. So when you get to fibrin, that's kind of the end of the discussion in terms of hemostasis. Because what fibrin is, it's basically a net that catches blood cells. And when you get blood cells caught in the net, that's a clot. And that's the goal. That'll be the temporary seal that allows the tunics to heal over time. Okay? And there are many steps. Okay, this is kind of the part that will drive students crazy, because you have all these different pathways and cascades, and whenever you have this type of a thing, there are kind of steps and things to remember. And the platelets, their plug is kind of a loosely knit thing, but when reinforced by the fibrin threads, it becomes a much stronger clot. And so how to get there is, there's 2 pathways that can lead to the formation of a very important enzyme, thrombinase, and that'll get you to one clotting factor called thrombin, and that'll finally activate fibrin. So here's a picture of the goal. You see the red blood cells caught in the spider's web. It kind of looks like that, the fibrin. Intermediate, late. So what I take away from this picture, you get a little bit fast, and you get much more later on. Okay, a little bit fast to stop the bleeding, a little more later to reinforce it and allow the tunics to heal. All right, so here's kind of the clotting factors that are known. Now, there's basically a few dozen, and we teach several of them. And what you need to know is that there are 2 pathways that can get you to this common pathway to get to fibrin. So let me clear this. Now, as I'm erasing the board, and you look at this list of steps there, just based on the number of steps, which one's faster, intrinsic or extrinsic? I heard both. The one that's faster is extrinsic, less steps, basically. go through the differences. And by the way, you see how like they have these Roman numerals? The medical community loves the Roman numerals. Can't stand them, but there they are, so we must know them. But I do want to give you a table, because it's like, remember learning the cranial nerves? You got the name, the number of cranial nerve 1, olfactory nerve. Now, this is the same kind of a thing, except for the clotting factors. And there's a good table on page 661 in the Mariev textbook. Page 661 has a table of all these factors, and I'm going to write all the ones on the board you got to know. I'll put that here, 661 Mariev. All the clotting factors are tabled out. I'll refer to some as name and number as I go on. Let's just kind of like see what we got here. We got intrinsic over here, extrinsic over here. The goal is to activate clotting factor 10. Clotting factor 10. Okay, that's the key. Now, the X, what's the difference? Why the names, intrinsic, extrinsic? The goal is to get fibrin, but extrinsic, it requires vessel damage. So pretend you got a blood vessel, got the tunica, whatever, and boom, there's a break in the vessel. Vessel damage. The injured cells will release what's called tissue factor. So I'll write that as a side note here. Injured cells release TF on that figure. The flowing blood is exposed to tissue factor. That's the extrinsic thing that the flowing blood normally does not see. Now the intrinsic, you don't require vessel damage. Remember, this can happen sitting in a test tube, right? But you know, in my example, there is vessel damage, and of course you can get it with vessel damage. So let me just kind of draw another break in the vessel there. Okay, so far, let's skip to what's really important in these pathways. If you look at the complex that forms, you get a complex that forms with tissue factor and factor 7. So I want to draw a little step here. Flowing blood sees the tissue factor, and basically you get a complex that forms TF and factor 7, VII. That's a complex that forms for the extrinsic pathway. For the intrinsic pathway, there's all these things that happen. It looks like 12 XII activates 11. And it looks like 11 will activate 9, and you also require calcium. Calcium itself is considered a clotting factor. And in fact, that table I referred you to calls calcium factor 4, clotting factor 4. But anyways, I'll draw an arrow going from this to this, this to this. And basically 12 to 11 to factor 4 gets you to factor 9 and 8. They form a complex at the injury site. IX9, VII 8. That's a complex that forms. And those complexes will activate clotting factor 10. Now, I skipped one thing here. Calcium is called, it's like a universal activator. It's also participating in the extrinsic pathway. So I'm going to draw calcium on this side too. It helps activate the factor 7. But once you get your complexes, this will win if this happens first. You'll activate factor 10. So I'm going to draw a big arrow from that complex that complex right in the center. When you activate factor 10, well, they call it now the common pathway, right? Because now they're going to do the same thing. This is common to both, starting here. Once you get to 10, I have another figure here. On the slide, the name for it is prothrombinase or prothrombin activator. Take your pick. So the name for 10, prothrombinase. It's an enzyme. Basically, factor 10 when activated is basically an enzyme, prothrombinase. And well, the common pathway is next, but just to sum up what we've done so far. The extrinsic pathway, the blood is exposed to the tissue factor. Think of it as a shortcut, factor 10. The intrinsic pathway comes along, it's a little longer in terms of time because it's more steps in the cascade. Think of it as just a longer pathway to factor 10. Now we get factor 10. Now it's our common pathway, our prothrombin activator. What does it do? Let me continue at the top of the board. I'm running out of room here. Okay, once we get to prothrombinase, just continue up there. This is the common pathway. Well, it's easy to see. I'm just going to copy what's there. What it does is it takes clotting factor 2 prothrombin. So I'll put the 2 in parentheses. It will basically become its activated form, thrombin. So that's a Roman numeral 2, not an 11. And they always put that little A for active. I never put the A. Thrombin means it's activated. Okay. Well, then thrombin, well then, in the cascade, it'll activate fibrinogen into fibrin. Fibrinogen, clotting factor 1, obviously when they call it 1, it's number 1, right? It's the best one. It's the one you're trying to get to. And fibrinogen is it's soluble in the plasma. You want to like take it out of solution. And thrombin will do that. Turn it into fibrin. Get your fibrin threads, and it's insoluble. It'll come out of solution, it'll make your threads, and hopefully it'll plug the leak. Okay, that's pretty much it. You get your fibrin threads. Fibrin is clotting factor 1. Okay, thrombin is clotting factor 2. Tissue factor is clotting factor 3. Calcium, clotting factor 4. You got them all tabled out. I gave you the page number reference. So what we see in this common pathway is we got 2 pathways to get us to factor 10, to get us to our common pathway. Both pathways are responding to the vessel injury. Okay? I don't want you to think only one happens and not the other. They both occur. It's just that the extrinsic is faster. Okay? Now, they also list platelet factor 3. That's also needed for platelets for the intrinsic pathway. I didn't list that before, but here it is on the slide. I did mention calcium. Calcium is important. It's considered a clotting factor. Okay, PF3 is not. I don't think it's listed there. No, I don't see it. Okay. Well, anyways, I showed you this picture before. This is the end result. It's the best picture of fiber mesh I've seen, and I've looked. And I really like the 12,000X. You can see how thick and strong these are. I mean, this is like if you get a big bad gash and you got to get stitches. I mean, what are the stitches for? They just bring the tissue close so it has a chance to heal. And that's what this is doing too. It's just, well, the next step post-coagulation. You want to retract that clot. You just want to pull the tissue together. Okay. Platelets pull on the mesh, compacting it for a tighter seal. You can allow for vessel repair. Called post-coag. Clot retraction. That allows for vessel repair. I'm not going to say much for vessel repair, but what are you repairing? The tunics. And that's largely driven by growth factors, and I'll give you a couple to know. PDGF and VEGF. PDGF, platelet-derived growth factor. This will help repair the TM and basement membrane. VEGF repairs the TI, the endothelium. That's TI, the endothelium, just to remind you of that. And once you get the tunics repaired, now you need a clot buster. You don't need that anymore. Okay, the vessel's repair. Maybe you have some scar tissue, but maybe okay, we call it clot busters. So basically, clot buster. The biological clot buster is plasmid. Plasmid. So we call the process of clot busting or anticoagulant fibrinolysis, right? Because it was the fibrin mesh that you formed, now you're busting it. So, plasminogen is the inactive form, plasmin is the active form. Our clot buster is plasminogen, that's the inactive form. Plasmin, that's your clot buster, right there. Now the factors that help it form or not is tissue plasminogen activator, TPA. So TPA is the one that gets you your plasmid. The one that's inhibitory is TPAI. Tissue plasmid activator inhibitor, it'll stop that. Okay. For example, I remember reading about this in heart attack. In heart attack, you got a clot in the coronary artery. It's a clot you don't want. So which would benefit a potential cardiac patient? Do you want plasmid or not if you get a clot you don't want, like in a heart attack? You want that, right? And in fact, TPAI is like a risk factor for heart disease because when you get clots when you don't want them, you need the clot buster. So again, you're thinking about that. So let's talk about clots in the wrong place. Usually you want a clot so the vessel can repair, but they can lodge in other places that can cause death, actually. Basically, I just want you to know the terms. Just getting you ready for your clinical days. Maybe you've heard of these terms, but didn't know quite what they meant. Now, for example, let's say you got a blood vessel in there, and you got a vessel wall, and you get a little break somewhere. The flowing blood sees the tissue factor, and it forms a clot right in your little break, right here. And that clot forms, but it doesn't completely occlude blood flow. Maybe it's like that. That clot that adheres to the vessel wall, you call that a thrombus. clot where you don't want it necessarily. But blood can still flow past it because it hasn't completely occluded the tube. So basically, a thrombosis would be if the injury would completely maybe the injury is bigger in this example, and the thrombosis would completely block blood flow. Let's call this one a thrombosis. Basically, blood just stops there, but blood can still flow around there. So maybe I have some ischemia or something. Wait, thrombus, thrombosis. Now, if a piece of the thrombus breaks off, it travels down the stream. That's called an embolus. So let's say for this top example, piece breaks off. Call that an embolus. But then it's traveling downstream to smaller and smaller blood vessels. Say maybe in the pulmonary circulation, where you have lungs, which are a vital organ that could cause death, right? Well, anyways, the idea is if you have a small blood vessel and the embolus gets stuck, or a large blood vessel because it's a large embolus, I mean, it doesn't matter. The point is the piece that breaks off and gets stuck is referred to as embolism. So how you treat clots in the wrong places. On the bottom I say anticoagulants, and I list a few. The clot formation or it dissolving, it just depends on what's circulating. If you have more TPA, aspirin, and heparin, you'll kind of lean towards dissolving. Okay, if you suspect stroke and like, oh wait a minute, oh, let's help you. Something's wrong. Okay, you want to stop stroke or heart attack or whatever it is. Or clot formation. Okay, maybe the surgeon nicks something and you're losing blood, and well, you don't want to keep giving them saline because you'll wash away all the clotting factors. Or they'll just bleed out. Okay, so you want the factors to accumulate. Okay, so it's all about whatever is circulating will favor the clot dissolving or forming. All right, so that completes this batch of slides. Yay. And for the rest of the time today, you are allowed to just stay and study the models.